You know that really frustrating feeling when your shoulder just decides it doesn't want to move properly. Like something's jamming it up, maybe with a good bit of pain too. Even simple things, reaching for something, finding a comfy way to sleep, becomes a nightmare.
Yeah, that's exactly the kind of frustrating reality we're going to explore today. We're focusing on adhesive capsulitis.
Right. Or as most people know it, frozen shoulder.
Exactly, frozen shoulder.
That name, it certainly paints a picture, doesn't it? That stiffness. And we've got some pretty detailed revision notes here to help us unpack it properly.
We do.
So our mission for this deep dive, really, is to give you a clear but thorough rundown of frozen shoulder. Everything from the definition, right through to complications. Kind of a high-yield overview.
Perfect for effective learning, yeah.
So let's dive in. What actually is frozen shoulder, fundamentally?
Okay, so at its core, adhesive capsulitis, or frozen shoulder, it's marked by this gradual start of pain. Then that's followed by a pretty significant loss of motion in the shoulder joint.
Gradual pain, then the stiffness kicks in.
Pretty much. And it happens because the capsule, the sort of casing around the shoulder joint, ligaments, tendons, the whole structure, it gets inflamed.
Inflamed.
And then it thickens up and actually contracts, shrinks down.
So that flexible casing becomes tight, less forgiving.
Exactly. That inflammation and the tightening, that's what causes the stiffness, the limited movement that's so characteristic. It's the glenohumeral thing, specifically that main shoulder joint.
Right.
And it can hit one shoulder, sometimes both. And what's interesting is sometimes it just seems to pop up out of nowhere.
Spontaneously.
Yeah, but other times it's linked to something specific, like maybe a rotator cuff injury, or, any reason why the shoulder might have been kept still for a while.
Okay, definition clear. What about the why, though?
Yeah.
What actually starts this whole process off, the etiology?
Well, like I said, the precise trigger isn't always totally obvious, but the notes point to a few common associations. Things like direct trauma to the shoulder, maybe a fall or a knock, periods of immobilization like after surgery or an injury, even just repetitive use, potentially.
So it's not always a single clear cause then?
Not always, no. But there are some really strong connections we definitely need to highlight. Diabetes mellitus is a big one.
Diabetes? Yeah.
Yeah, a significant link. The resources suggest maybe up to 20% of people with diabetes might get frozen shoulder at some point.
Wow, 20%. That's huge.
It is, and there's a theory that maybe the high glucose levels could affect the collagen in the joint capsule, make it stiffer.
Ah, okay. Possible biological link there.
Potentially, yeah. Other things linked are thyroid disorders and some autoimmune conditions, too.
Interesting. So knowing these links, who is actually most likely to get this? What are the key risk factors we should know?
Okay, so key risk factors. Age is definitely one. It's much more common in people over 40.
Over 40. Got it.
There's also a slightly higher rate in women compared to men. And as we just talked about, diabetes is a major, major risk factor.
So middle-aged, female, diabetic, that combination flags it up.
That's definitely a key demographic, yes. But other things play a role too. Having had a previous shoulder injury or maybe shoulder surgery increases the risk.
Makes sense.
And like we mentioned with the causes, any kind of prolonged immobilization of the shoulder is also a risk factor. And finally, the notes also mention thyroid issues and even cardiovascular disease as potential risks.
Right. Quite a few things to consider there.
Oh, yeah.
Okay, let's get down to the nitty-gritty. What's happening inside the joint itself? The pathophysiology.
Okay, so the two main things happening are inflammation and then fibrosis, both within the shoulder joint capsule.
Inflammation and fibrosis.
Yeah. Think of the capsule like a stretchy bag around the joint. First, it gets irritated and inflamed, kind of like getting swollen and sore.
Okay.
Then, over time, this irritation causes the bag itself to thicken and actually shrink. That's the fibrosis part. It's like scar tissue forming, making it less flexible.
So the capsule, which should be roomy and allow movement, becomes tight, thick, almost sticky.
That's a great way to put it, sticky. And often the amount of synovial fluid, which is the joint's natural lubricant, also reduces.
Making it even harder to move smoothly.
Exactly. And on top of that, you can get adhesions, like bands of scar tissue forming inside the joint space, physically blocking movement. It's this whole cascade leading to that locked up feeling.
So it's really restrictive.
Yeah.
Now, if someone comes in with shoulder pain and stiffness, it's not always frozen shoulder, right? How do doctors tell it apart from other conditions?
Yeah.
What are the differentials?
That's a really important question. Yeah, several other things can mimic it. You've got to think about rotator cuff problems like tendonitis, inflammation of the tendons.
Okay.
Bursitis is another one, inflammation of the little fluid sacs, the bursae, that cushion the joint.
Right.
Then there's osteoarthritis, the wear and tear arthritis in the shoulder joint itself.
Mm-hmm.
And also shoulder impingement syndrome, where tendons get pinched when you lift your arm.
So ruling those out is key. It's not just about stiffness.
Exactly. You need that careful examination and history to differentiate and get the right diagnosis, which obviously affects the treatment plan.
Makes sense.
Yeah.
How common is this condition overall? What's the epidemiology look like?
Well, the data suggests it affects about 2% of the general population. So not incredibly common, but certainly not rare either.
2%, okay.
And as we mentioned, it mainly hits people in their middle years, typically 40s, 50s, 60s, and yeah, slightly more common in women.
Good to have that context. So let's paint a picture for the listener. What does it actually feel like day to day? What are the typical clinical features someone would experience?
It usually starts quite gradually, often just an ache in the shoulder, but then the pain ramps up over weeks or months.
Okay, pain first.
Pain first, generally. Then comes the really defining feature, that limited range of motion, especially turning the arm outwards, external rotation, and lifting it out to the side, abduction. Those become really restricted. And this stiffness really starts messing with daily life. Things like reaching up to a high shelf, doing up a zip at the back, even just brushing your hair can become difficult or impossible.
Wow.
And a lot of people report the pain is worse at night. It can really disrupt sleep.
That sounds miserable. Really debilitating.
It really can be. And it tends to follow a pattern usually described in 3 phases.
3 phases.
Yeah. First is the freezing phase. This is where the pain is often worst and the stiffness is progressively setting in. This phase can last maybe 2 to 9 months, something like that.
Freezing. Getting stiffer and more painful.
Exactly. Then comes the frozen or adhesive phase. Here, the pain might actually lessen a bit sometimes, but the stiffness is really the main issue. Movement is very restricted. This can last, say, 4 months, up to about a year.
Frozen. Just really stiff.
Yep. And finally, there's the thawing or recovery phase. This is where things gradually start to improve. The range of motion slowly comes back, but this phase can take a long time, anywhere from 1 to 3 years, sometimes even longer.
Goodness, that's a potential long haul.
It can be. And remember, pain usually starts before the stiffness really bites. Either shoulder can be affected, but interestingly, it's often the non-dominant arm.
Huh. Wonder why that is.
Not entirely sure, but it's an observation. The key thing is all shoulder movements eventually become restricted, impacting daily stuff and sleep. Oh, here's a quick memory tip for the phases. Think freezing, getting painful and stiff, frozen peak stiffness, maybe less pain, and thawing, slowly loosening up again.
Freezing, frozen, thawing. Got it. That's helpful. So how do you actually confirm the diagnosis? Are there specific tests, scans?
It's interesting. The diagnosis is mainly clinical.
Clinical. So based on talking to the patient and examining them.
Exactly. A good medical history, finding out how it started, what makes it worse, and then a thorough physical exam. There isn't really a single blood test or scan that says, yes, this is frozen shoulder. But the absolute key finding on examination is that marked restriction in passive external rotation.
Passive, meaning when the doctor tries to move the patient's arm?
Precisely. It's not just that the patient can't lift their arm themselves, it's that even when relaxed, the examiner physically can't rotate it outwards very far. That's a huge clue.
Right, a real mechanical block.
Yeah. And because of that, in most typical cases, x-rays aren't usually needed, especially initially.
Oh.
Yeah, because x-rays in frozen shoulder often look completely normal. They don't show the capsule problem. They're mainly useful if the presentation is unusual or if things aren't getting better with treatment, just to rule out other bone issues.
Okay.
Things like blood tests or maybe an MRI scan, those are usually only done if there are red flag symptoms, things that might point towards something more serious going on.
Good to know. Avoids unnecessary tests. Okay, let's try putting that clinical skill to the test. Here's a quick scenario. A 55-year-old woman comes in, gradual shoulder stiffness, pain, worse when reaching overhead. On exam, which passive movement would you expect to be most significantly restricted?
Based on what we've said, that would almost certainly be external rotation.
External rotation, perfect. Okay, diagnosis clear. Now the crucial part, what can actually be done about it?
Right.
How is frozen shoulder managed?
Right, management. The main aims are pretty straightforward. Relieve the pain, improve that range of motion, and get function back to normal, or as near normal as possible.
Makes sense.
The first-line approach is usually conservative, so non-surgical things. This typically includes painkillers like NSAIDs, nonsteroidal anti-inflammatories to tackle the pain and inflammation.
Like ibuprofen.
Yeah, exactly, provided there are no reasons the person can't take them. Physiotherapy is absolutely key too.
Physio. What does that involve?
Specific exercises, stretches, and often manual therapy techniques from the physio to gently mobilize the joint and stretch that tight capsule.
Okay.
Another common option, particularly in the earlier, more painful stages, is a corticosteroid injection directly into the shoulder joint.
Steroid shots. Do they help?
They can be really effective, yeah, especially for reducing that intense pain and inflammation, which then often allows the person to engage better with their physio exercises.
Right. Makes the physio more tolerable.
Exactly. Surgery is really held back for the more severe, stubborn cases that just haven't responded well after several months of these conservative treatments.
So it's a stepwise approach generally.
It is. The notes mention considering a referral to an orthopedic specialist if things aren't improving after, say, 6 months or so of consistent conservative therapy.
Okay.
So breaking it down, pain relief paracetamol, NSAs if suitable, really important, encouraging gentle movement early on within pain limits to stop it seizing up even more.
Keep it moving gently.
Yes. Then the structured physiomobilization, stretching, the steroid injections for that initial pain and inflammation burst, and then, if really needed, the surgical options.
What are those surgical options?
2 main ones mentioned are manipulation under anesthesia, or MUA.
Manipulation.
Yeah. The patient is asleep under general anesthetic, and the surgeon carefully moves the shoulder through its full range to physically break down the adhesions and stretch the capsule.
Wow. Sounds quite forceful.
It's done carefully, but yes, it's a physical stretching. The other option is an arthroscopic capsular release.
Arthroscopic keyhole surgery.
Exactly. Tiny camera, small instruments go in, and the surgeon actually cuts or releases the tight parts of the capsule surgically.
Okay.
It's really important to stress, though, no single treatment is a guaranteed magic bullet for everyone long term. It needs to be tailored, and, things like psychosocial factors can also play a role in recovery.
Right. The whole person picture. Okay. That management approach makes sense. Maybe another memory tip here.
Yeah, good idea. For management, think. Step 1, cool the freeze with meds and maybe injections. Step 2, melt the ice with physiotherapy and stretching. Step 3, only if needed, break the ice with surgery like MUA or release.
Cool. Melt break. Nice. Okay, what about the long run? What's the prognosis generally like for someone with frozen shoulder?
Overall, the outlook is generally pretty good, especially with the right management. It's often described as a self-limiting condition.
Self-limiting, meaning it gets better on its own eventually?
Yeah, in many cases, it will resolve by itself over time, even without any specific treatment. But that over time can be quite long, typically anywhere from 1 to 3 years.
1 to 3 years. That's a long time to be dealing with it.
It is, and that's why treatment is usually recommended. Early intervention, that multidisciplinary approach with doctors, physios, that can really help improve the outcome, potentially speed up recovery, and lower the chance of long-term problems.
So intervention helps, even if it might get better anyway eventually.
Exactly. Patience and sticking with the treatment plan are really key.
And are there potential long-term problems? Complications that can linger even after the main condition resolves?
While most people do recover well, yeah, some potential issues can remain. A small number of people might have some persistent pain or stiffness that never fully goes away.
Okay.
This could lead to some lasting functional limits, maybe trouble with specific overhead or behind-the-back movements. And sometimes, because the shoulder mechanics have been off for so long, it might lead to secondary problems.
Like what?
Things like muscle weakness around the shoulder, or maybe making the shoulder more prone to other issues down the line, like rotator cuff problems or impingement.
So getting it treated properly isn't just for the immediate relief, but also to try and prevent these knock-on effects.
That's a good way to put it, yes. Proactive management helps minimize those risks.
Well, this has been incredibly useful, a really thorough deep dive into frozen shoulder. So to quickly recap, it's this common but definitely frustrating condition, pain and stiffness, the main players. But understanding the phases, the risks, the management really helps. And the prognosis is generally good with the right approach.
Absolutely. And for anyone revising for exams like the MSRA, getting these key points clear, the definition, the phases, that key sign of restricted passive external rotation, the management steps, that's really high yield stuff.
Definitely. And speaking of revision, if you're studying for the MSRA, do check out passmsra.com. Loads of great resources there.
Yeah, and also freemsra.com is another excellent site for study materials too. Both well worth a look.
Fantastic. Well, thanks again for joining us on this deep dive. Understanding conditions like frozen shoulder is so vital for providing good care.
Couldn't agree more. Keep learning. Keep questioning.
And finally, just a little something to chew on. Given that really strong link we discussed between diabetes and frozen shoulder, what wider sort of systemic things might be influencing how conditions like this develop and resolve in the body? Something to ponder. Until next time.